Thank you so much for being a part of today's CME. We're excited to be able to host this event for you. And please note that this presentation will be recorded, and by attending, you agree to be recorded. We know that many of you are using your lunch hour, so we definitely want to make sure that we start on time and we also end on time, and in respect for your schedules as well. All right, so with that, I want to welcome you all. My name is Tiffany Kai-Kamanu, Community Relations Manager with CalOptima Health. I'm so pleased to welcome you to today's workshop, which will focus on the Medicare Annual Wellness Visit, tips and tools. We have two esteemed physician champions who have been working on the Annual Wellness Visit Toolkit. And so we will hear from Dr. Calvé and Dr. Harward today as our featured presenters. We are pleased to host a CME CE focus on the healthcare needs of older adults. We recognize that older adults are the only age demographic that is increasing in the county and statewide, while all other age groups are decreasing. So with that in mind, we want to ensure that healthcare services related to older adults receive the attention they deserve in preparation to care for Orange County's current and future older adults. So Dr. Calvé and Dr. Harward will discuss the types of annual wellness visits and components of each, the patient benefits that can result from the visit, the different tools and resources available for successful completion of the visit, and documentation needed to attain appropriate reimbursement. Now, before we get into our program today, just a few housekeeping details. We do have a Q&A portion at the end of the presentation, so please type in your questions in the Q&A box, and it's bottom of your control panel. And really, to facilitate that Q&A portion, we ask that you put it in there in lieu of the chat box. We have put everyone on mute to minimize disruptions. And a reminder regarding credit for completing part of the course, continuing education may not be granted. Thus, if a person attending the course leaves before the course is over, the certificate of completion cannot be issued. Please allow time after the training to complete an evaluation. We value your input and feedback so that we can support our providers with the annual wellness visits. The evaluation will be displayed or popped up after attendees exit the training, and it will also be sent to you in a follow-up in 1 week. Actually, it's 1 day after the training. And for those of you who complete the evaluations, there's an opportunity drawing for a Starbucks gift card. The CME certificate and certificate attendance will be sent via email to you after you complete the evaluation by UCI School of Medicine Continuing Education Office. Please allow up to 8 weeks to receive it. The CE certificate will be sent via email from CalOptima Health's Population Health Management Department after you complete the evaluation. Please also allow 8 weeks to receive that. Now it is my pleasure to welcome and introduce CalOptima Health's Chief Medical Officer, Dr. Richard Pitts, to the virtual stage for welcome remarks.
Hi, everyone. Thank you for joining us today. Thank you, Tiffany, for that introduction. And I want to thank our two expert speakers for speaking today. I just want to welcome you on behalf of CalOptima. CalOptima is going through another transition, and we are really focusing on partnerships in our community, and especially with the major hospitals and our medical groups that care for our patients, and also Orange County Medical Association, who is partnering with us on this presentation as well. The information is going to be very helpful. This is an important topic. There are financial incentives that are available to complete this besides the regular fee that's paid. And also, more importantly, is the fact that annual wellness visits have been shown to help overall care of our patients and try to keep them out of hospital as well. So with that, I want to welcome you. Thank you for sharing your lunch hour with us, and there is continuing education as long as you complete the requirements as Tiffany outlined. So with that, I'm going to turn it back to Tiffany for the rest of our program. I have to get ready for a board presentation here, so I will unfortunately not be able to attend, but thank you very much again. Go ahead, Tiffany.
All right, thank you, Dr. Bitts, for really kicking off today's presentation. Next slide. Now it is my pleasure to welcome and introduce Dr. Helene Calvé and Dr. Mary Harward. Dr. Calvé received her MD from UCLA and is board certified in both internal medicine and infectious disease. Initially working in academic medicine, she transitioned to public health and served as health officer in the city of Long Beach and as deputy health officer in Orange County. During her more than 20 years in public health, she has had special interest in STIs, TB, and older adult health. In 2018, she went part-time to study and volunteer in global health and received certification in tropical medicine. In March 2020, she returned to public health full-time to assist with COVID response and leads a team which has responded to over 700 COVID outbreaks in long-term care facilities. Dr. Mary Harward received her MD from Duke University and is board certified internal medicine and geriatrics. Dr. Harward held internal medicine faculty appointments at Baylor College of Medicine and the University of Florida for 10 years, where her research and educational interests included preventative medicine. Since moving to Orange County, she has maintained her private practice and staff appointment at Providence St. Joseph Hospital in Orange for the past 25 years. Now it's my pleasure to welcome both Dr. Calvé and Dr. Harward.
Thanks, Tiffany, Bao-An, and Dr. Pitts for inviting us to speak with your group today. I'm just going to go through a real quick introduction with a little history of the annual wellness visit toolkit. What are these visits and why do them? And then the bulk of the presentation will be for Dr. Harward, who is actually delivering these visits, and she'll talk about the different components of the annual wellness visit and the tools that we have assembled in the toolkit to help providers deliver the visit. And then at the end, we'll circle back and actually visit the web page. Next slide, please. So something seems to be missing there. Anyway, another thing that I've been involved with, I became involved with older adult health when I was deputy health officer at Orange County. Yeah, it doesn't matter, at the healthcare agency. And another thing that we did through the Orange County Healthy Aging Initiative, or OCHI, is we developed an older adult web page or an older adult dashboard that has specific data to those 65 and over in Orange County. And actually, for some of these data points, it compares the Orange County older adults with those in other parts of the state and other counties in the state. So as you all know, the older adults are not the healthiest population in Orange County. About 60% have hypertension. More than 10% have dementia. We actually are pretty high compared to the rest of the state. More than 25% have diabetes, heart disease, or both of them, and about 1/3 have a disability. So this is really a good group to focus on for a wellness visit to try to prevent some of those secondary complications that can occur from these chronic diseases. You can visit that website at the link at the bottom of this slide. Next page, please. Or next slide. Thank you. So Orange County Healthy Aging Initiative, or OCHI, formed in 2013. It was myself and another, our COO of public health at the healthcare agency, who joined with 2 professors from Cal State Fullerton, who also were involved with older adults. We gathered some other folks interested from other governmental organizations and NGOs, all of us interested in promoting senior health and wellness. The toolkit was one of the first projects we worked on, and that was because at the time in 2013, it was a fairly new Medicare benefit, just came on in 2011. And we realized that most older adults are cared for by providers who don't really have specialized training in geriatrics like Dr. Harward does. And so for the rest of us non-geriatricians, we'd hope that by getting together some tools and resources, we could help non-geriatricians perform the visit. The first version was a sort of hard copy that we handed out to over 250 providers' offices in Orange County. Then a second update in 2017 was all online. but a lot of documents were ones that we had created or downloaded from places and then uploaded. So our latest revision last year, again, is all online, and we're trying to link to more resources that stay up to date. So the actual web page link is there, the next bullet down. This is for providers, though. If you have patients or consumers who are interested in learning more about the annual wellness visit, the Council on Aging has developed a website that is consumer focused, and they're doing promotion to consumers about this and other Medicare preventive services. Next slide, please. So this is just a couple of snapshots from the website. That top one shows the 8 different sections that we have, and you can click on those. It can take you immediately to the content in that section, or you can just scroll down, and below is just a snapshot of section 3, which has a lot of the tools that we assembled for doing screening for depression, fall risk, cognitive impairment, and substance use. Some of the instruments are available in other languages, as you see in the PHQ-9. Those will be sub-bulleted, and you can, free to download those for your use. Next slide, please. So what are the wellness visits? Well, it's important to know that these are not annual physical exams, and it's important to let the patient know that so they don't get disturbed if you don't slap a stethoscope on their chest. This is really an opportunity to focus on prevention, on the preventive services, and on patient wellness. So you do screen for some conditions, and more importantly for risk factors for things that can affect the patient's health and negatively. Some tests are included in this exam or this visit, but others may be ordered as a result of this visit. In the words of CMS, they are committed to promoting the appropriate use of Medicare preventive services, and they offer a broad range of services to prevent disease, detect disease early when it's more treatable and curable, and to manage disease so that complications can be avoided. So next slide, please. So why are we promoting the AWVs? Why did we create a toolkit? Why is CalOptima going all this, this effort to do that? It's because for several reasons. First of all, most insurance plans cover preventive services like cancer screenings and vaccinations without a share of cost. Now, the annual wellness visit we're talking about is specifically a Medicare benefit. It may not be covered in other types of insurances, but other insurances may have different kinds of wellness visits. In general, though, these the preventive services like cancer screenings, vaccinations are underutilized. And the visit itself is underutilized. When we first started our effort for this toolkit, we requested some data from CMS and found that among fee-for-service Medicare beneficiaries in Orange County in 2012, only 14% received the annual wellness visit. That came up to 25% in 2018. Then unfortunately with the pandemic, some of our data collection has dropped off a little bit. And among certain CalOptima segments also, utilization has been very low. So obviously CalOptima is hoping to increase that. And we know that over the past 2.5 years, many older adults have kind of stayed away from the doctor, have stayed away from healthcare for fear of COVID. So we know that many of them are behind on their need of preventive care. So this is the time to really try to get them back on track with an annual wellness visit. Next slide. There are benefits to the health system itself, and the primary one is to help meet quality goals. So the graph on the right there is from a published in the American Journal of Managed Care, shows that of 11 different services that there was higher utilization of these quality measures or these outcomes in folks who had annual wellness visits compared to those who did not. 7 of those were statistically significant. The other 4 were not, but they were increased. Some things were decreased as well, but those bottom 2 really, the annual wellness visit is not focusing on disease like heart, failure, or other things like that. It's really more focusing on prevention. There's also some data to suggest that it can decrease costs. So from that same article, they found that patients who had the annual wellness visit had a reduced adjusted total healthcare cost of just under 6%. So not huge, but every little bit helps. That savings was mostly in hospital acute care and outpatient non-ED, and really most of the benefit was seen in highest acuity patients. CalOptima itself, though, has seen that among their members who had an annual wellness visit in 2020, that there was a risk-adjusted inpatient PMPM that was 24% lower in 2021 compared to members who did not have an annual wellness visit. Now, they do acknowledge that that may be due to some better risk identification or other cofactors, but I think there's enough data to kind of suggest that these visits do pay for themselves overall. Next slide. So benefits to the provider, of course, there's a reimbursement for the visit itself. Also, if you're part of Medicare MIPS, you can use the annual wellness visit to increase your quality scores, which may lead to increased revenue. And it also is an opportunity to assess and report risk-adjusted diagnoses for Medicare Advantage patients. If you have questions about exactly how much that reimbursement would be, don't ask me. I'm not the person performing the visits. Ask your biller. There are additional services that can be, sort of tacked on at that time or other. So really, that would be the best person to ask about that. The annual wellness visit can also help close many pay-for-performance quality measure gaps, such as those listed here, specifically the NCA HEDIS measures. And then I think it's always an opportunity to improve your care of the patient and to strengthen your relationship with the patient. Next slide. I think the strongest data, though, or the strongest argument for doing that is increased utilization of preventive services. So 3 studies quoted here. The first one among Accountable Care Organization Medicare beneficiaries, they had a significantly higher utilization of 7 preventive services. Among fee-for-service Medicare beneficiaries, same thing, 62% higher utilization of preventive services than among those who did not receive an annual wellness visit. And then if you could just click once, please, to show the slide, or advance once to show the slide. Yeah. So this last study with the graph on the right there is from AARP, and that looked at all Medicare Advantage enrollees in a certain region, so over 1.7 million people. And that showed that among these 11 services, there was a higher utilization among those who received annual wellness visits compared to those who did not. So I think it's pretty good evidence. Is it all due to the annual wellness visit, or does it mean that people who get those are also more likely to get other services? I don't know, but I think there's strong enough data there to suggest, and I think hopefully we all agree that it's a good idea to get your preventive visit, to get your preventive services like colonoscopy, mammogram, et cetera, et cetera. Next slide. There's benefits to the patient as well, not as much good data on that, but it is an opportunity for the patient to talk to you about their wellness instead of focusing on disease, and most importantly, to learn about resources to address health risks. They also should come out with a personalized plan and schedule for needed services, and then an opportunity to get those things actually scheduled. Next slide. So there are 2 kinds of exams: the initial preventive physical examination, which, as I said, is really not a physical exam. It is a wellness visit. That's done in the first 12 months after initiation of Medicare Part B coverage, may be performed by a physician or other non-qualified non-physician practitioner, and includes a history, a brief exam, counseling, and education. We're not going to be focused, this one's known as the Welcome to Medicare visit. We're not going to be focusing on that one today, but on the subsequent visit. So next slide. The annual or yearly wellness visit. This can take place not during the first 12 months of starting benefits or in the first 12 months since an IPPE or the last AWV. Again, can be performed by a physician, a qualified non-physician practitioner, or a group of professionals who are working under the direct supervision of a physician. Next slide. So just really quickly, there are the coding. But I want to make sure that I'm now going to transition over to Dr. Harward to actually cover what is the annual wellness visit and what tools have we pulled together for that. So next slide and take it away, Dr. Harward.
Okay. Thank you for attending today, and thank you, Helene, for getting us up to this point. Again, I'm going to go over the components and the nuts and bolts of the annual wellness visit, hopefully providing some tips and other information about how to make this work in your office. I'm not going to be too specific about every component of it because all of this is contained both in the Orange County Healthy Aging Initiative website, and also Medicare Learning Network has extensive details on this, both of which are available in the resources included in your information for this. And again, you want to think of your initial visit as sort of establishing the baseline. This is probably what you'll be doing first with most of your patients, because the annual wellness visit or the initial even preventative services welcome to Medicare visit was not available when many of our patients turned 65. So during that initial annual wellness visit, you really want to concentrate on getting your database of the medical and family history, the list of current providers, and that you'll be able to simply update on all your subsequent visits for the annual wellness visit. You'll include measurements of height, weight, calculate the body mass index and the blood pressure. Also, we'll talk more about assessing for cognitive impairment, assessing for depression, reviewing the functional ability of safety, establishing a written screening schedule or a preventive service plan, providing personalized health advice and referrals, and advanced care planning if appropriate, and reviewing for use of opioids and substance use disorders. I'll go ahead and mention briefly the advanced care planning, which can be provided as part of an annual wellness visit. This usually is a conversation that may or may not result in completing a document, such as a durable power of attorney for healthcare, a living will, an out-of-hospital do not resuscitate order, or a physician's order for life-sustaining therapy. Again, if this is included as part of your annual wellness visit, it can be billed separately, or you could do it at other visits. You don't have to do the advanced care planning at the annual wellness visit, but it's a good opportunity. Also, the patient doesn't have to participate in that. It's not a requirement. But should you do that, and again, other information is available on the website, you can have a separate charge in addition to your annual wellness visit component. Another thing about the annual wellness visit, it is done annually, but that's based on the month of which it's performed. For example, if you did an annual wellness visit in September 14th of 2022, you could do the next visit on September 1st of 2023, as long as it's went in within the same month of the previous year. So I've had some physicians say that they find it easiest just to try to schedule the annual wellness visits within the patient's birth month. So that way everybody remembers it. Okay. Next slide, please. These tools to get the provider and patient ready, when we mentioned sections 1 and section 2, this is what you'll find on the website listed below on the slide. Again, provides an overview for the provider, a process map, which we'll go over toward the end of our discussion. Also, a video that shows how the physician can wrap up the visit after you or your office staff have gathered all the information from the patient, the health risk assessment, the screening tests or the screening exams that'll be done if needed. And then use the physician's role to really tie everything together, plan the preventive services plan with the patient, identify for your staff what needs to be scheduled, what resources need to be made, and then moving forward with the next visit for the patient. Okay. Also, I'll mention the home safety checklist. This is something that I always give to my patients to take home with them after they complete. This is also included at the website for OCHAI. It has a lot of useful information as to how they can improve their house to help prepare for increasing frailty as they get older. Next slide, please. The sample health risk assessment we'll look at briefly. Again, looks at the self-assessment of the patient from their health status. And I think you might be surprised sometimes as someone who you might look at who has multiple medical problems, a lot of frailty, maybe using a walker, may require some assistance, but they do assess themselves as being in pretty good health. And you want to emphasize that is what their attitude is toward themselves. But then look and see if there are other things that you can identify that can help them continue to age successfully. So you want to, the HRA will look at the self-assessment of health status, psychosocial risk, behavioral risk that may influence their health status, their self-assessment of their ability to perform activities of daily living. This includes dressing, feeding, toileting, grooming, and ambulating, bathing, okay. And then the instrumental ADLs are instrumental activities of daily living, which include housekeeping, using the phone, paying bills, getting to and from office visits or shopping, and managing medications. We'll also talk about the use of depression screens, both within the annual wellness visit and at subsequent visits. Next slide, please. Again, this is an example of a health risk assessment. You may find others online that are helpful for you. You may find with certain electronic medical records, you may have a health risk assessment embedded in the template of the annual wellness visit. So you may want to look at that first to see if you can make this occur more easily. It's maybe possible to get certain health risk assessments available for electronic completion. I don't have the information on that, as I happen to still go back to the pen and paper one in my office, but those are likely things that may be available. Next slide. And I'll point out specifically, which we'll come to, that the HRA does include the depression screening. Just go ahead and do it for all your patients, the PHQ-2, which asks them to assess how often these two symptoms occur. And next slide, please. So during the visit assessment, you want to look at depression. And again, you're doing that with a PHQ. The information on the website includes how to score that. If a person has a score of 3 or above on the PHQ-2, you are going to want to consider an in-depth discussion about depression symptoms, and also using an additional test, a more extensive depression screening test, such as a PHQ-9 or a geriatric depression scale. The purpose of the annual wellness visit is not to take care of everything, but to identify what you need to follow up on. So it is an option to do these more in-depth depression screens at a subsequent visit, at which time you should be able to bill for depression screening and have the more in-depth discussion with the patient. Also, fall risk. You'll be able to identify if the patient has a fall risk, both on some of the questions in the health risk assessment regarding have you had a fall recently, and the risk of falling assessment that's included in the information on the website that you can provide to the patient before their visit, and the safety assessment if there are risk factors in their housing environment that may put them at increased risk of a fall. Those would indicate that you may need to look more closely at the fall risk. The STEADY is a comprehensive website that has it's a toolkit and a website that has all sorts of information on it. And they do recommend several quick in-office assessments for fall risk: the timed up and go, the 4-stage balance test, and the 30-second chair stand, all of which are described in detail at this website. But these are for people without an assistive device. So there's not a good test for someone who's already using a walker to determine what their balance is. But you can assess in your just by watching them walk into the office or walk into the exam room. And I think that can be one of the most useful parts of a geriatric exam if you have the opportunity to watch somebody walk into your office or to walk down the hall. It will help you determine if you need to look more closely at their gait. And again, the purpose of assessing the fall risk, both for folks who are independently ambulatory and those already using an assistive device, is to determine if referral to physical therapy is needed or an assessment of the appropriate use of the assistive device, such as a walker or cane. Now, you don't have to do a balance or a gait indicator or gait screening test. You can just note in your note that you observe the patient ambulating without difficulty in your office. Same for cognitive function. You don't have to do it every time, but if you get hints from the health risk assessment that the person is missing medications or having trouble with finances, or the patient or family member shares with you that there are memory issues noted, you can consider doing the mini cog, which we'll review shortly. Again, the purpose of the annual wellness visit is to screen, to identify issues that will need further evaluation. So if on the mini cog, you find that there's some impairment, you will want to bring the patient back at another time and do the St. Louis University Mental Status Exam, the SLUMS, which does take a little bit longer. So in order in a busy office, you may not be able to schedule your annual wellness visits with sufficient time to follow up on everything, but certainly a visit in the near future to follow up either on depression or cognitive function may be indicated. More recently for the annual wellness visit, they're encouraging screening for substance use and opioids. Again, not required, but can be easily done with the TAPS, which is included in the on the website and in the packet. Next slide. This is the mini cog. What you do is use 3 words. There are 6 specific versions of the words. You don't make the words up yourself. You ask the patient to remember it. First, you give them the 3 words, they remember it, then you ask them to draw a clock, then you ask them to remember the 3 words. For the clock drawing, it's worth 2 points, and they only get the 2 points if they do several portions of the clock drawing correctly. They need to put the numbers in pretty accurately, mainly making sure the 12, 3, 6, and 9 are where they should be. If the other numbers aren't quite equally spaced, that's okay. The other key component is to make sure, because you've asked them to draw the hands of the clock at 10 minutes after 11, that one hand is at the 11 and another hand is at the 2. They don't have to be as specific as to have the hour hand as the short hand and the long hand as the minute hand, but again, they have to get the numbers right. So if you find that either and again, the cutoff is 3, so if they get all 3 words but can't draw the clock, they would just barely pass, okay? Doesn't mean you can't follow up with a more extensive exam to look for cognitive impairment, but technically that would be considered okay. Although I will note that some experts think the cutoff should be 4, which I guess you couldn't because there's no 4 on that. The clock is either 2 or nothing. So if they can draw a clock but can't remember the words, again, you would want to follow up on that. And these are screening tests. Next slide, please. Then we come to the preventive services and personalized plans. This would be section 4 of the OCHI AI website. Again, we'll go over an example of this. There are also many other preventive services plans that might be available. There may be one in your EMR already that you can certainly use. We'll review shortly the services listed at the prevention guidelines that are available on the Medicare or the MPS quick reference chart. Make a note that Medicare does recommend following the U.S. Preventive Services Task Force. This is a volunteer task force composed of all sorts of health professionals in the healthcare fields. They do an extensive review of the medical literature available for either tests or procedures or behavioral interventions that may help prevent illness. And they constantly update their recommendations. They also give a grade to the recommendations, saying either A or B, that yes, we have good data to show that this works to either prevent illness or save lives. Even going up to D, saying that when we view the information on this, we don't find that it's of any benefit. So Medicare recommends following the U.S. Preventive Services Task Force, which again is readily available. Whenever there's an update, it's usually published in JAMA or Annals of Internal Medicine. But interesting, Medicare will cover for things that U.S. Preventive Services Task Force doesn't find helpful. So you'd want to have that discussion with the patient, saying, well, gee, should I get a Pap smear after 65? You can say that U.S. Preventive Services Task Force doesn't recommend it, but Medicare will cover it, and have that conversation with them. Again, we have male and female personal prevention plans, including the recommended timetable, indication for behavioral therapies, and documenting the referrals made and information and education provided, all of which you'll want to include in your medical chart as documentation of your annual wellness visit. Next slide, please. This is the Medicare Learning Network for Medicare Preventive Services. This doesn't mean you have to do all these things. For example, glaucoma screening is provided by an ophthalmologist, but these are available preventive services that are covered by Medicare. You'll notice that you'll see a T by some of these items. This means it can be performed by telehealth. So the annual wellness visit, the initial one and the subsequent ones, can be performed by telehealth. You may note that the initial preventive physical exam, and all these are in alphabetical order, is not a telehealth because they do require the exam for that to include height, weight, visual acuity, blood pressure, and an EKG, which can be done at that initial visit. But everything else can be covered, or again, the other two exams can be provided by telehealth. I will point out a couple of these that sometimes it's easy to overlook. Lung cancer screening is covered by Medicare and will be addressed during your annual wellness visit. For people aged 50 to 77 who have a 20-pack year smoking history and are either continuing to smoke or have stopped within the past 15 years. And the recommended method of screening would be a low dose, I'll emphasize a low dose CAT scan of the chest. Also note the bottom, the ultrasound AAA screening. This is a one-time screen for someone who has a family history of an abdominal aortic aneurysm, or is a male aged 65 to 75 who smoked at least 100 cigarettes. They can have an ultrasound of their abdomen to screen for abdominal aortic aneurysm, but this is a one-time occurrence. And also hepatitis C screening, hepatitis C antibody blood test is covered for anyone born between 1945 and 1965. And again, simply ordering the test, hoping to identify people with asymptomatic hepatitis C infection who may benefit from treatment. A lot of these other issues are going to be related to high risk. Not everybody needs screening for all these things, but there may be some high risk conditions that you'll identify through your annual wellness visit, and then we'll be able to implement the preventive services. Next slide, please. So for the preventive plans, this is an example checklist. And again, every patient won't need all of these done. And that's why we have the section for not indicated at the end. Emphasize the vaccines. This is becoming more and more important. Annual flu shots. The pneumonia vaccines are changing. You may be familiar with the polysaccharide vaccines, been available for years. There was a brief period of time when they were using PCV13 for adults. They've now changed it to, if anyone hasn't received any vaccine, they can receive a PCV20 or a PCV15. If anyone only received the older polysaccharide vaccine, or polysaccharide 23, they should also receive PCV or PCV20. And that does seem, if they've already gotten both the PCV13 and the PPSV23, then they're good, okay? So it's just a matter of making sure one gets a polysaccharide vaccine and a conjugate vaccine of some sort, but this is again recently changed and can be a little bit confusing. Just point out that we're focused on Medicare patients here, but elderly Medicare patients. For many of your Medicare patients may not be 65, and there may be additional indications for polysaccharide or pneumonia vaccines for patients who are less than 65 based on their risk factors. I'm going to point out the importance for tetanus vaccine. Generally, tetanus with Tdap, tetanus with diphtheria and acellular pertussis is preferred because we continue to have cyclic pertussis outbreaks that also include illness amongst adults too. Okay, and COVID-19 vaccine, as you're aware, is constantly changing. But keep up to that, and your annual wellness visit is a good opportunity to update that. Next page, please. This is something that's also included in the website that you can just check off for the patient. Check off that if they're smoking, you want to refer them to tobacco cessation services. Give them the information on going to a quit smoking class. Brochures on not enough exercise, not enough sleep, etc. So this would be an individual plan that you would complete. The referral and action could be as simple as you checking it off and referring it back to your staff who can make the referral. Some of them are a little more specific with setting goals that you would like to choose, and you would want to make sure this is part of the chart, so you'll bring it back. They'll bring it back to you so you can see if the goals are met throughout the subsequent visits throughout the year. Next page, please. For the resources and referrals, section 5, lots of information. This is, I think, one of the strongest parts of the annual wellness visit, because I've been in practice for probably 15 years before I started working with this group and wasn't aware of just how much is available through the Orange County Health Agency. So again, based on your HRA answers and questions, you can look through what's available and immediately make referrals. The other thing can be specific information from resources either through the county. Also, a lot of our pamphlets are from the National Institute of Aging, which is an excellent resource. You can order pamphlets from them for your office free of charge. They have a topic on almost everything that may affect elder health, including information on online health information. Can you trust it? And that's important, I think, for physicians to review also, because if we're referring patients for medical information online, we want to make sure that we're using reliable sources and not some blog that somebody just wrote for themselves. Okay, so you want to make sure that anything you refer, give to your patients would be validated and would be accurate information. I think, and all the referrals that we have in here should meet that. And the next page, please. Again, it points out some specifics. And again, this is included in the website, that if you think the patient needs more sleep, we have the sleep brochures. You think they need aerobic exercise, there's a referral to the Office on Aging for exercise classes in senior centers, which frequently have exercises there. If they need, if there's food insecurity, there's a number in a website for referral to help with that. Next page, please. Yeah, again, mention some of the things. And again, as you identify these things through your visit, you'll probably find that many patients may need strength, balance, and exercise. Those can be done through physical therapy. Tai Chi is becoming more and more popular, plus has been shown to help improve balance. The Office on Aging can probably help you find Tai Chi classes. You want to review their nutrition. Make sure they understand how to use their medications. Screen for depression with follow-up if needed. Assess for sleep patterns, which can be very difficult to treat during as we get older. Assess for forgetfulness with follow-up as needed. And again, assess the level of pain. Patients, as we get older, everything does seem to hurt more. And to help look at other issues in education, again, provided in section 6, that may help relieve some of that. Next page, please. Elder abuse, again, even though not directly a part of the annual wellness visit, if you identify that as a provider, you are a mandated reporter. And again, the information is provided in the website as to how you file that report and in what situations should you file that report. Next page, please. Again, we also include lots of other information in the website for OCHAI, including advanced care planning resources, as we were talking about, things my loved ones need to know about me, which can be part of that. Just in general, tips on geriatrician, and the DMV, the Department of Motor Vehicles report form. If you do identify a memory issue, a physical issue, or other things that make you question the person's ability to drive, that would also need to be reported to DMV. Okay. And the next page. And Helene, I think you were going to jump in here.
Yeah, so we had a kind of flow chart of how the visit could potentially work in your office. Of course, all these are just suggestions, whatever works best for your workflow. And a lot of the documents that we came up with could be modified for your EMR or for your purposes. Always important to first verify eligibility for the annual wellness visit. Make sure they haven't had another visit within the prior 12 months. If they're not eligible, of course, then you're going to have to reschedule for a later time. If they're eligible, schedule the visit. You can send them the patient materials found in section 2. That's, again, a letter kind of going over the visit, as well as the home risk assessment, a self risk, the HRA, and a fall self-risk assessment, that if you wanted to have these patients complete these ahead of time, they could do that. Some of those are MS Word documents you could put on your letterhead. When the patient arrives, you can have your staff do the measurements that are needed to review the HRA, possibly highlight problem areas. They can score the PHQ-2, which is those questions 34 and 35 on the HRA. If it is over 3, as Dr. Harward said, you could administer, if there's time, administer the PHQ-9 or the GDS at that point, or schedule another visit later on to do that, to go into more depth. If there's need to have a mini cog done or the TAPS done, you could have your staff do those ahead of time. Also, the timed up and go could be performed by staff, although I think it's helpful to have the physician or the provider view that to see how someone does, do on that exam. It's a good visual thing. But you could have staff do it as well. Document all that, and then basically packages all up for the provider's review to go over the different points that need to be done, to give the education, to develop the preventive plan, order referrals. Then staff can follow up on providing the information, providing the referrals as needed, and then you repeat in 1 year. So next slide. If we could maybe, this is just some of the resources. So the top one is the toolkit. Second one is the Council on Aging consumer webpage. Then the Medical Learning Network webpage that has all the preventive services and specifics about them. This has a lot of information about the annual wellness visit itself, as well as the interactive table. But if we can click on the top one and go to the website, great. Go ahead and scroll down. So you see here on the left, or there we go. Scroll back up just a little bit more. Okay, so there's a watch this video down here. Yeah, so on the far left is when you do that annual wellness visit info for the public, that takes you to the Council on Aging website. When you go on this watch this video, you'll find about a 15-minute video. Well, it should be up there. It got taken down, and I'm trying to get them to put it back up there, featuring Dr. Harward and myself and Dr. Debbie Rose from Cal State Fullerton, going over the approach to the annual wellness visit, as well as different components of the toolkit. Then when you scroll down, you see the different, oh, good, the video's back up. Great, thank you. I kind of got freaked out when that was down. So you can click on each one of those, or you can just continue scrolling down. So continue scrolling down, and you'll see for each section, there's just a little bit of a introduction as to what's in there. You see on the pre-visit, hold on right there, pre-visit material for patients. Again, these are samples, the patient letter, the health risk assessment. You can use your own, but we did have these translated into Spanish and Vietnamese. They are in, at least the patient letter is in MS Word, so you can put it on your letterhead, whatever, but you may choose to use your own things. So these are all just suggestions, the fall risk assessment, home safety checklist, etc. Keep scrolling down. These are the different assessments that Dr. Harward referred to. Again, that you can just click on those. Some of those take you to websites, others take you to particular documents, and in particular, the STEADY toolkit for the fall risk assessment has videos that describe how each one of these tests are done. Continue scrolling down. I got the preventive services plans for men and women as well. And again, this can be modified for your purposes. I'm sure everyone has EHRs. They may have one in there already. So you may just want to look at this for content. Also, our HRA was specifically developed for older adults. There's a lot of HRAs out there, but ours was really geared towards older adults. Scroll down a little further. Then we have our resources and referrals. So these are a lot of local organizations that can help out. Say the Caregiver Resource Center, if you're having issues or if the family's having issues with caregiving for the older adult. Meals on Wheels, chronic disease self-management classes. So all of these should have brochures and or link to those particular websites. There's also a nice information assistance resources that is a list of a lot of useful phone numbers for local agencies. Scroll down a little further. Then the patient education, these are the brochures that Dr. Harwood referred to. Many of those are available free of charge from the National Institute on Aging. Some of them are from other sources. We did kind of review them to try to select really the best brochures that we could find on these different things. In particular, there is the Balance Basics is a nice locally developed thing by Dr. Deborah Rose, and she's agreed to allow that one, and the Balance Basics and Strong and Stable brochures have a lot of good exercises on that. Continue, and I think that's pretty much it. So then we have the elder abuse section and the other things. So I think we can stop at that point and go to any questions.
I just wanted to mention briefly that the annual wellness visits, both the initial and the subsequent, first and the subsequent, can be combined with a mid-level office visit. So if you're seeing a patient back for a routine problem, you can make the office visit and do the annual wellness visit at the same time. You would bill them separately, and your bill would need to provide appropriate modifiers. It would need to be a 99213 for the physician office visit or below. If you identify a minor problem during the annual wellness visit and have sufficient time to address it, you could also do that and also do the subsequent office visit in addition to the annual wellness visit for that same day.
Yeah,
All right. Oh, were there any comments? All right, I'm sorry. I think I jumped in. Dr. Calvé, were you going to say something? I apologize.
No, I'm just gonna thanks to people for hanging in there with us, and we're happy to answer any questions. I hope they go to the website and find things useful. If the MS Word documents are not up there, shoot us an email and we can get you those if you wanted to incorporate those into your approach to the annual wellness visit.
All right, very much. We actually have just about 7 more minutes here, and we have 2 questions. If you haven't had a chance to type in your question, please do so now in the Q&A box there. The first question is, understanding that the Staying Healthy assessment will go away in 2023, will this toolkit replace the SHA and be considered as an individual health education behavioral assessment, IHEBA, for this population?
I don't have an answer for that.
What is a Staying Healthy
I'm not
assessment?
familiar with Staying
Is that a
Healthy,
CalOptima specific thing?
You know, I won't be able to speak to that. I don't know if it's a Medicare or Medi-Cal benefit. So perhaps this is one of the questions we can research. We want to make sure that we give you the right response. We have a comment. The HRA is the same as the okay. So second question, we have 3 questions here, or 4 questions. Is the screening audiogram a required component of AWV, I'm guessing, annual wellness visit?
No, it's not. But if you assess issues with hearing, you can refer for that, yeah, or do it in your office, yeah.
All right, very good. We have a question here. Can we perform the annual wellness visit on patients with Medicare who are younger than 65? I have assumed that all Medicare patients are eligible regardless of age.
Yes, it's covered under Part B, yeah. So they should go through with that, yes.
Fantastic. Thomas, you know what? We're unable to mute participants. So if you wouldn't mind typing your question in the Q&A box, that would be fantastic. We have a question here from Leah. Is there a specific Medicare annual wellness visit billing code when we are combining a subsequent visit with the annual wellness visit?
I would defer to your biller for that, just to be sure the answer is correct, yeah.
Okay, very good. As a gynecologist sees a lot of elderly patients, are there any other sources?
I'm sorry, could you repeat the question?
Yes, the question is, as a gynecologist who sees a lot of elderly patients, are there any other sources, I think resources, that might be available for a gynecologist?
Well, certainly we provided some information, resources in the, there may be on urinary incontinence in terms of, I think, I'm not sure if that we included that one in the resources because actually the HRA does ask about urinary incontinence. So yes, refer info brochures or referring to a specialist if needed. This is focused on the primary care providers. In many cases, the gynecologist is the primary care provider for some older patients, so they might be able to incorporate some of that. But we don't have anything specific for gynecologists other than the cancer screenings and probably incontinence issues. Yeah.
Yeah, no, and I think if the annual wellness visit is done in a gynecologist's office, they'd still have to follow those guidelines put out by CMS for what the main components of it are. So.
Yeah.
All right, and we did get some clarification regarding the SHA. Deborah Flores indicates that SHA is under DHCS. Question from Gregory. I saw that a number of community agencies were shared for community supports. Might it be expanded to say OC Navigator website to reach broader groups like Alzheimer's Association, which has a 24/7 helpline?
I think we do have some links to other resources, certainly Alzheimer's, OC, Alzheimer's Orange County. Yeah, we don't just use necessarily county ones. There are some others embedded in that. Yeah.
Right. I think the OC Navigator website, though, is newer, though. Isn't that the one that just launched within the last month or two?
Possibly. I know that there's quite a few resource and referral tools now.
Yeah, there's a lot of those. So we obviously are not like doing constant surveillance for those and adding those to there. But we find that older adults do seem to like, obviously, in person, and the Office on Aging assistance line, I think, is really helpful for older adult specific needs. So that's a prominent number that we feature.
All right, and we have a question here. Can medical assistants help with performing any of the annual wellness visit components, such as the mini cog, or is it advisable that the physician do this?
I think that would depend on how you work with your office staff. I mean, it's pretty straightforward. You read through, and in fact, the form we have included about the mini cog on the website also kind of gives you specific instructions as to what to say to the patient. You simply let them know you're going to give them 3 words, ask them to remember it, make sure they repeat the words and understand it, and then hand them the piece of paper and say, please put, draw a clock face and put the hands of the clock at 2 minutes after 11. So it would depend on how the communication between the medical assistant and the physician, because there can be some subtle differences. If the person really had difficulty with things and just had no idea what to do, the medical assistant would, of course, want to communicate that to the physician in addition to whatever the final score was. But there isn't anything that says that has to be administered by a physician or a nurse practitioner or PA.
All right, thank you for the clarification. And our final question is, these components and billing requirements apply only for OneCare Connect annual wellness visit, or is it all for all annual wellness visit Medicare?
Again, I'm not sure what OneCare Connect is.
It's actually a program through CalOptima Health for members who have Medicare and Medi-Cal. But I think the question,
this would be for all Medicare participants. Yeah. Yeah.
All right. Okay, we have 2 more questions. See if we can get through them real quickly. What is your recommendation to determine if a patient who is new to your clinic have not already had an annual wellness visit done in the last year? I have patients who are new to our system.
Yeah, you'd want to have your biller or someone in your office should be able to contact Medicare and find out if that's been billed for, and if so, when. Yeah.
All right, fantastic. And so we are up to the hour here. Just wanted to share that the PowerPoint as well as the recording will be sent after today's training. And I also want to thank Dr. Calvi. I apologize, my dog is barking.
Okay.
I just want to thank Dr. Calvi and Dr. Harward for being our subject matter experts. And thank you all for being a part of today's training. We want to wish you the best for the rest of your week. Thank you.
Thank you.
Thank you.
Sorry about that. Okay, looks like Dr. Calve jumped off the call.
Oh, do you want us to stay on for further questions if
Oh,
anybody has?
no, I think we're good. It seems like we went through all the questions. I think there was only one question that we didn't answer. It was a staying healthy assessment. So I'll do a little bit more research. Val-Ann, do you know anything about the staying healthy assessment?
And I just add in the chat regarding to that.
Oh, okay. Let's see here.
I see a lot of Q&As showing up on my screen. So I don't know if there were people that had other questions that we didn't get to, if we need to reach out to them in some way.
Well, I facilitated the questions
Okay,
in the Q&A. So I think we got through them all.
Yes.
actually.
maybe some were duplicates. Yeah, okay, very good.
Awesome. Okay, so I see Anna's response for we still have participants who are leaving the room. But I'm wondering, Val-Ann, as part of your follow-up email with the PowerPoint and the recording, if you could add that response in that as well.
Sure.
I'll do it. I'll do it.
Oh, fantastic. Thank you.
Very good. Thank you very much. Okay.
All right. Thank you.
Uh-huh.
Have a great day, everyone. Bye-bye.